Hi everybody, this is going to be our class presentation voice PowerPoint, and we're going to start with fluids in the body. So you know that fluids are necessary to maintain that homeostasis of the body. You know, all the body organs work together to make sure that we have maintained fluid balance, whether it's the hypothalamic pituitary regulation, the kidneys through the RAS system, the adrenal cortex through aldosterone and cortisol, cardiac GI regulation. It's all working together. So fluid, let me get rid of my picture here so it's not in the middle of the thing. All right, see if that's better. So fluid movement helps to keep our temperature, our cell shape. It helps us to transport nutrients, gases, waste, our electrolytes, and the amount that we are taking in needs to equal the amount that's lost, which is the big reason we do intake and output at the hospital. The composition of the fluid is kept within a narrow range, and the content of the water varies on age, gender, and fat content. So the older we get, our percentage of water decreases, which put the elderly at a higher risk for fluid imbalances. And normal fluid intake for an adult is 2 to 3 liters. So insensible loss, this is that loss that we can't measure it or see it. And so our respirations are one of the big ways that there's, just invisible vaporization. Insensible loss is normally 600 to 900 milliliters per day. If we have a high fever or increased respiratory rate, increased exercise, that is going to increase the amount of water loss. Tachypnea will cause increased water loss, and bradypnea, which is decreased respiratory rate, will cause decreased loss. And as we were talking about surgery recently, if you think about a GI surgery, a big open abdominal surgery, they're going to have an even increased risk for insensible loss. And so, when I've taken care of those big GI surgery patients, I was really monitoring their urine output because of the chance for them being dehydrated from surgery. Now, sensible water loss, this, makes more sense. This is our fluid loss from urinating, stools, wounds, vomiting. If they had an NG tube, typical adult loss is about 150 to 200 milliliters per day, and severe diarrhea may cause fluid losses that exceed 5,000 milliliters a day. Holy cannoli, that's a lot of fluid. So intake of fluid, intake of fluid can be from IV fluids. If we're irrigating, peritoneal dialysis, and you'll learn more about that in a future med-surg class. And then any fluid intake that has liquids at room temperature. So that includes ice, water, all of our drinks, electrolyte replacements. Things that are often forgot about are ice cream, popsicles, Jell-O. So when you're doing your intake and output, those are all things that we should be doing. And then calculation of fluid gain or loss. 1 liter of fluid equals 2.2 pounds. And that's why our scales is so important to let us know if somebody's fluid balance is up or down. My mom has heart failure, and I'm always asking her, what's your weight? Because she'll be short of breath, and I'll be like, how much is your weight up? And, getting her to understand the importance of her weight took a little bit of time, and she's not a dumb woman. She's very smart. So fluid compartments, we have the intracellular fluid, which is about where 2/3 of the body is inside the cells. Extracellular fluid is about the other third, and those are outside the cells. So interstitial fluid refers to fluid located in the spaces between the cells and the lymph. And then intravascular fluid includes fluid that is actually in the blood, the plasma. And then transcellular fluid is very small amounts of fluid contained within, special things. That would be like our GI tract, our pleural spaces, our synovial spaces, peritoneal, intraocular, pericardial. And those all have very specific amounts. And then about 2/3 of the ECF is in the interstitial space. The The transalar space is about 1 liter. The GI tract, we have those fluids, 3 liters to 6 liters is secreted. And as I mentioned earlier, that vomiting or diarrhea can cause serious issues. So fluid spacing. So first spacing, which interesting, I never really thought of it as this way, but that's normal distribution, when we have normal distribution of ICF and ECF. Second spacing is when you have that abnormal accumulation of interstitial fluid. That's that edema. And so interstitial fluid, again, that space is between the blood vessels, the lymph system, and cells. And then third spacing is when fluid is trapped where it is difficult or almost impossible for it to move back into the cells or blood vessels. And so ascites would be an example of fluid third spacing. So what mechanisms help us control fluid and electrolyte movement? The beginning of your textbook talks about the osmotic pressure and how that can be expressed as either osmolality or osmolarity. And people use those terms interchangeably, but they're really not. Osmolality is used to describe fluids inside the body, whereas osmolarity pertains to fluid outside of the body. So when I think of osmolality, that is, our plasma. And then when I think about the fluids outside of the body, then I'm thinking of like our urine. So fluids that have the same osmolality or tonicity would be considered isotonic. And isotonic fluid, there's no movement between isotonic fluids. Where solutions where the solutes are less concentrated are considered hypotonic, so less hypo. And solutions where the solutes are more concentrated are considered hypertonic. And we'll go through some examples with that. So fluid therapy, many patients may need some IV fluids if they can't take oral. So like, as we talked about that, intraoperative and postoperative period. Other patients may need some corrective replacement therapy for losses that have already occurred. So they come in, they've already been dehydrated, or they had a major burn and they've lost fluids. So we're going to give IV fluids as order, and we're going to really monitor the rate of the infusion. And so with that, we would obviously be monitoring our IV site, we would be monitoring lungs. All of those things are vital signs. And then we would also maintain adequate intake, oral intake. And so we want to make sure that, somebody's able to drink independently and that they can swallow effectively. And if they're unable, then we need to make sure that we're assisting appropriately. So isotonic solutions, again, these are the solutions that are just equally concentrated. So I added this picture down here because I just love this picture of understanding your hypertonic, isotonic, and hypotonic. So this is my cell. I introduce it to isotonic solution and it doesn't change. And so isotonic solutions have an osmolarity between 240 and 340. And these are going to be crystalloids. And crystalloids is like an umbrella term. Examples of these crystalloids would be normal saline, 0.9 normal saline, lactated ringers, and then D5W. So as we go to hypotonic solution, again, this is where there's less solutes, so hypoconic. So if we again look at our picture, hypotonic solutions are going to cause those cells to swell. And hypotonic solutions have an osmolality less than that 240. Fluid shift can cause cardiovascular collapse because it's pulling fluid from the intravascular space. They can also cause increased intracranial pressure. An example of a hypotonic solution is 1/2 normal saline. And then again, hypertonic solutions, this one is going to have more solutes than the others. It causes the cells to shrink. So it's going to cause the intracellular space and to shrink and the extracellular space to expand. So it's going to pull it from the cell into the extracellular space. Hypertonic solutions have that osmolality greater than 340. With this one, the big thing is to monitor for this fluid overload and pulmonary edema. And when you think about that and you think about pulmonary edema, think about your ABCs, airway, breathing, circulation. So pulmonary edema is going to cause those crackles where we talked about that with our module 2. How were we telling between crackles that were pulmonary edema or crackles that were atelectasis? So fluid overload, pulmonary edema, and with that pulmonary edema, we would expect the O2 sats to drop, respiratory rate to go up. And so hypertonic solutions that you should know would be, and it's kind of slid down, so I slid that down. My slide is a little off there. So D10, 3% saline, D5, 1/2 normal saline, and D5 normal saline. And so again, remember half normal saline is 0.45 and normal saline is 0.9. So again, this is just our picture that I like so much that I put on all of those pictures, kind of reminding you hypertonic is going to cause the cell to shrink, isotonic, no change in our cell, and hypotonic is going to pull fluid into the cell. All right, so colloids. Colloids are plasma expanders, and so these are going to pull fluid into the bloodstream. And so if you remember when we were talking about, if somebody had had a big estimated blood loss in surgery, what would we do? And we talked about possibly giving blood, other things that they can give in the OR, or, when we have somebody with major signs of hypovolemia would be albumin, which is that protein, dextran, and hetastarch. All right. So hypovolemia. What I really want you to get out of this section, hypovolemia, it's when we have extracellular fluid volume deficit. So this can be from abnormal loss of body fluids, you haven't drank enough, you have shifting from the plasma to the interstitial fluid space, versus dehydration. So fluid volume deficit and dehydration are not the same. Dehydration refers to loss of pure water alone without the loss of sodium. So again, that dehydration is just pure loss of water without that loss of sodium. Isotonic dehydration results hypovolemia of fluid volume loss. The hypertonic dehydration, deprivation of fluids, usually seen in the elderly. And then hypotonic dehydration results of sodium loss in greater amounts than free water, often seen with low sodium diet or diuretic overuse. So the interprofessional care for anybody with hypovolemia is that we're going to try and replace fluids and electrolytes. So orally, potentially through blood products, and balanced IV solutions. So when you think of balanced IV solutions, we're thinking of those isotonic solutions. Now, hypervolemia, this is when we're looking at fluid volume excess. So either this can be caused from an excess intake of fluids, abnormal retention of fluids, so maybe they're eating too much salt, interstitial to plasma, fluid shift. Typical symptoms from hypervolemia, again, is that weight. So we're really watching that weight. Again, remember, 1 kilogram equals 1 liter, and we know that 1 kilogram equals 2.2 pounds. So when we have somebody with hypervolemia, we may be administering diuretics like furosemide or hydrochlorothiazide. They may be on a fluid restriction, restriction of sodium intake, and if they have ascites or a pleural effusion, they may have removal of that either through a thoracentesis or a paracentesis. So nursing care, we're going to, again, weigh the patient every day. And with daily weights, it's always the same time of day, wearing the same amount of clothing, ideally the same scale. And again, we've talked about that. 1 kilogram equals 2.2, which is 1 liter of fluid. And that's a lot of fluid to be carrying around extra. Obviously, we're going to be doing intake and output. Cardiovascular care, we're going to be watching for excess and deficits of our ECF fluid is reflected by, blood pressure changes, JVD, that jugular vein distension. In the next picture, I added a picture of that. Orthostatic hypotension may be evident in patients with fluid volume deficit, and I see that even more in my elderly patients. Versus fluid volume excess, we may see the edema. And so one of the ways that we're going to assess for edema is pressing with our thumb and forefinger over the edematous area, and then grading scale is usually like a +1 slight edema, which is 2 millimeters, to 4, which is pinning edema, up to 9 millimeters indentation. And that's not only how far it goes down, but then how quickly it comes back. So this is our image of JVD, and you can see here in the neck how those are just like sticking out. And the way you do that is in like a 45-degree angle sitting up in the bed. So for anybody with fluid issues, we're going to be assessing for skin turgor. And in an elderly, I know on here in the picture, it's showing to assess on the forearm, but in an elderly, the best way, let's see if I can get my mouth to work, the best place to assess skin turgor is actually on the chest. So you're actually going to, take a little fold of skin, you're going to pinch it. Again, here it does say about the sternum. That's going to be like the best place in your elderly patient. And, you pinch it up. This would be normal, and this is tented. And so if we have that tented, then that can indicate that we have fluid volume deficit. So other nursing care, respiratory care, fluid excess and deficit affect our respiratory status. We talked about that excess fluid can cause that pulmonary congestion and pulmonary edema. The patient may experience shortness of breath. Again, those crackles upon auscultation. And if they have a deficit, they may have an increased respiratory rate, as well as decreased tissue perfusion. So when I think about that, I think about my cap refill. My cap refill would be decreased too, even though that's under respiratory care. We'd also see the hypoxia potentially with the decreased tissue perfusion because we're not getting the oxygenated blood there. Patient safety, of course, we're going to be monitoring for level of consciousness changes. We can see cerebral edema with the changes. We're going to be assessing for our level of consciousness, pupil responses, and voluntary movement of extremities. Do they respond when you say their name? When you walk in the room, do they open their eyes? All right, so that is fluid volume in a nutshell. We will work through some activities together in class. I hope that this voiceover PowerPoint is helpful for you, and I look forward to doing the activities in class with you. Thank you for watching.